נעבור כעת להרצאת האורח המרכזית של הבוקר, שגם הפעם תינתן על ידי פרופסור נתן הרמן. פרופסור הרמן הוא מהדמויות הבולטות בעולם הפסיכיאטריה והגריאטרית, הפסיכוגריאטריה. הוא לשעבר ראש החטיבה לפסיכיאטריה גריאטרית באוניברסיטת טורונטו ובסאניברוק Health Science Center. כיום הוא מנהל את השירות הפסיכופרמקולוגי במרכז מרחבים לבריאות הנפש והמוח. לזכותו למעלה מ-900 פרסומים, מאות מענקי מחקר בתחום אלצהיימרס וקוגניציה ותסמינים נוירופסיכיאטריים. בכנס הקודם פרופסור הרמן דיבר איתנו על הצורך בהתמחות בפסיכוגריאטריה בישראל, ונתן הרצאה מאלפת בנושא. הרצאתו הבוקר, שגם תינתן באנגלית, היא בנושא Cognitive Assessment in the Elderly, to screen or not to screen. בבקשה.
Good morning. It's a pleasure to be here for the second time in 2 years, so I can torture you again with my English. I'm also very pleased that Professor Avraham is here because I've been a visiting professor at Tel Aviv University for 6 years, and you'd think at some point they would invite me to stay permanently. Anyway, we're talking today about cognitive screening in the elderly, and first of all, I want to make it clear that I have no pharmaceutical or drug company or industry support at all. I have current research grants from the Canadian Institute of Health Research, the Public Health Agency of Canada, and the American Alzheimer's Disease Discovery Foundation. Although none of that research will be talked about today. So just to give you an overview of the presentation, I'm going to start with a clinical case. I want to then talk about cognitive screening tools very briefly. We're going to talk about the benefits of screening. We're then going to talk about the risks and harms potentially of cognitive screening. And then finally, we're going to look at the clinical guidelines that have been published and then hopefully make some clinical recommendations at the very end that will be helpful for you if you are in clinical practice. So let's start with a case. So this is the story of Miriam, who's a 68-year-old widowed retired teacher who lives alone in her own apartment. And she came complaining to me of feeling sad for 2 years. Her history was thus. She had persistent low mood, anhedonia, or loss of pleasure, and she was sleeping poorly for about 2 years. She was withdrawn socially. She had lost interest in her previous activities, which used to be gardening and attending groups in her Beit Knesset. She was fatigued, she had poor appetite, there was a 4-kilogram weight loss over the last couple of years, and she also had several falls in the last 6 months, which was a concern. She saw her family doctor, who diagnosed major depression and treated her with sertraline, 100 milligrams. Sertraline is Lustral. I really try to avoid using drug trade names. It's a terrible habit they have in Israel. Nobody knows the generic names of drugs. People only know the trade names. You should only use generic drug names. Anyways, she was treated with sertraline for 100 milligrams for 14 weeks. That is a very therapeutic dose for a patient who is in their 60s, and she had a minimal response. The family physician then referred her to the Kupa psychiatrist, who saw her and switched her to duloxetine, which is Cymbalta. She was treated with up to 90 milligrams, again, a very therapeutic dose for a 68-year-old woman, for 12 weeks. She had a partial response, but then seemed to lose the improvement that she had got on it. And so that psychiatrist added mirtazapine, which is Remeron or Miro. She tolerated it very well, but her mood was unchanged. There was no benefit from this. So she's had 2 very good therapeutic trials of antidepressants and had basically no significant response. So then she was referred to me for a geriatric psychiatry consultation with the working diagnosis of treatment-resistant depression. Okay, so the first thing I do is I spend most of the session with my patient's family, whoever comes, to provide me with collaborative history rather than the patient themselves. And the family reported some very interesting history. They said that she had good days and bad days in terms of her cognition. She occasionally would forget conversations they had the previous day, but they attributed this forgetfulness to her depression. Doctor, look, she's so depressed, you got to give her a break with respect to this. She got lost once while driving to her daughter's home. And again, the family explained this away. It was at night, it was late. She had been over at our house for several hours and she was very tired. So they didn't think there was anything of concern there. In terms of her medication adherence, they admitted that sometimes she did not use her full month's supply of her medication, but not a huge amount was missing. There was a significant functional decline. She had recently stopped cooking for herself, paying bills, and managing her household tasks independently. And again, the family said, look, she's so depressed. What do you expect? She just doesn't have the energy. She just doesn't have the interest to do these kind of things. And then I asked specifically about paranoia because it's a very common problem associated with cognitive impairment. And the family, again, tried to explain, well, yeah, she's mildly suspicious about the neighbor. She's always had a very bad relationship with the neighbor. So we don't think that there's anything that you need to be concerned about with respect to that. And then I checked through her notes and I asked the family, and nobody had assessed her cognition in 2 years, okay, since this all began. Okay, so naturally, that's what I did. I'm a cognitive specialist. I specialize in Alzheimer's disease and other dementias. And so the first thing I did was a MoCA on her. And she scored 19 out of 30. And to remind you, a score of less than 26 on the MoCA is indicative of cognitive impairment. She lost points in virtually all the areas, but most significantly in terms of her delayed recall, she scored 0 out of 5 on delayed recall. And that, again, is very consistent with something like Alzheimer's disease that presents with an amnestic pattern early on in the illness. Ordered a CT scan, it demonstrated cerebral atrophy and small vessel disease, nothing that would be out of the unexpected at her age. She had completely normal blood work, and so I revised her diagnosis. I said that she had a major neurocognitive disorder, likely Alzheimer's disease or mixed with cerebrovascular disease, and her neuropsychiatric symptoms included depression and apathy. So we're going to come back to Miriam a little bit later and talk about the implications of all this. But just in terms of the key points here, the neurocognitive disorders frequently masquerade as late life depression. Apparent treatment resistance should trigger cognitive screening. That should be a clear indication for cognitive screening. The depression here was real, but it was a neuropsychiatric symptom of the underlying dementia and not a functional or psychiatric major depressive episode that we would typically see in other patients without evidence of neurodegenerative disorders. So it was not a primary mood disorder. Okay, so let's step back for a second and talk about what cognitive screening is. It's brief standardized tests to detect possible cognitive impairment. It is not a diagnostic assessment. I have to emphasize this all the time, but it's rather a guide for further evaluation, where you need to do more tests. The target domain should be as many as you can possibly do in a brief period of time that is acceptable to the patient. So you'd like to try and test for memory, orientation, attention, language, visual spatial skills, and executive function. It can be used anywhere in a clinical setting, in primary care, in psychiatric clinics, in geriatric medicine clinics, in neurology clinics, and in rehab medicine. Now, it's very important to differentiate screening an asymptomatic patient population, so with no evidence or no history of cognitive or functional impairment, from screening as part of case finding. So this was case finding, right, with Miriam, because I had done the history, I had determined that there was some evidence of cognitive impairment in the history and some evidence of functional decline. And so that gave me a very good rationale to actually screen the patient cognitively. But some would argue cognitive screening also belongs in primary care clinics or in health clinics in the mall, where you want to screen a large asymptomatic population to identify cognitive impairment early. And we'll see if that should be done or not. So one of the important things is that you must have a tool that's easy to administer, that's acceptable to the patient, and that is valid and reliable. And as you all know, if you're here today, there are dozens and dozens of cognitive screening tools. The mini mental state exam, the Montreal Cognitive Assessment, the GP-COG, the SLUMS, I love that name, the mini-COG, the TICS, the Rollins, it goes on and on and on, many, many different types. And we're going to talk about a few of them that I think are pretty cool and worth considering. So first is the granddaddy of them all, not really the granddaddy, but was one of the first assessments. Was the mini mental state examination, was produced by Marshall and Susan Folstein, as well as Paul McHugh at Harvard University. And they published the mini mental state in a paper in Psychiatric Research in 1975. It is now currently, and has been for the last several years, the most cited mental health article of all time. Okay? There are tens of thousands of citations of the mini mental state examination. So that gives you an idea of how important it is. It's easily 30 items, easily administered, takes about 5 to 10 minutes, very well accepted, reliable, valid, and the validity and the reliability have been established in multiple different languages. As I said, there are multiple language versions, including Hebrew. Scores of 23 or less are generally indicative of significant cognitive impairment. That's not a diagnosis. Remember, it is indicative of cognitive impairment only. There are many weaknesses. If you have any problems with language, you're going to have trouble with the mini mental state examination, even though it's, as I said, been translated into more than 30 languages, translated and validated in more than 30 languages. If you have significant sensory impairment, like hearing or visual impairment, you will have difficulty with the mini mental state exam. The scores are influenced by age and education level, and you have to correct for them. There is no executive function tested, which is a problem. It's not a diagnostic instrument, as I mentioned, and for the last 5 or 6 years, unfortunately, after being widely available for free for decades, the authors sold it to par, and it's now copyrighted, and theoretically, you need to pay $1 US every time you administer the mini mental state examination. Now, they will not go out and charge clinicians for using the mini mental state. This is really so that if it's used in a clinical trial, the drug companies will pay for its use. So you don't have to worry if you're using it clinically. So this is, of course, what the mini mental state looks like. Again, I'm sure most of you are familiar with it. This is a multi-language copy of it, including Hebrew. And again, very simple to administer, pretty well accepted by the patients. They don't mind doing it as long as you introduce the reason that you're screening them cognitively. They actually find that it's very well accepted. The more popular instrument today is the Montreal Cognitive Assessment. It is also 30 items. It includes an assessment of executive function, so that it helped the significant weakness of the mini mental state examination by adding a component of executive function, or a large component of executive function, actually. It's more sensitive, but somewhat less specific compared to the mini mental state examination. It's better for picking up mild cognitive impairment, vascular cognitive impairment, and frontotemporal dementia because of the additions of the executive function testing. It too requires adjustments for age and education. And again, although it was around for many years free of use, in 2019, the authors required certification for use. Now, this is a course that you take online. It costs $125 US. I have personally not taken it, and I use the MOCA all the time. So don't worry about that. It's very easy to learn, very easy to administer. This is what the MOCA looks like. Now, the really cool thing about the MOCA is that most of us believe this is the test that President Trump keeps taking. He doesn't describe it accurately, which would make sense because he's probably cognitively impaired, but it probably is the test that he keeps getting administered. And for those of you who watch Jimmy Kimmel, you know Jimmy Kimmel took it on the show and did very well, and so he proved that President Trump has nothing to brag about just because you can do well on a MOCA. There are a number of other tests I just want to talk about briefly. The RUDAS is the Rowland's Universal Dementia Assessment Scale. This is a very nice instrument. It was designed in Australia specifically for Aboriginal populations so that it would be basically culture-free and less affected by education. So a really cool tool, and it's been, again, validated and translated into a number of languages. I cannot find it in Hebrew. Does anybody know, is it available in Hebrew? It is. Okay, excellent. Okay, somebody's going to have to send it to me because it's a really nice tool. Again, it's a 30 instrument item where scores of 23 or less would be indicative of significant cognitive impairment worth examining. So it's a nice tool. The mini-cog is a great instrument, and I like to teach this to medical students who don't have a lot of time to do a lot of cognitive testing. But so easy to do. You give the patient 3 words to try and remember. Say, I'm going to ask you these 3 words in a few minutes from now. You ask them to draw a clock, and then you ask them for the 3-word recall. And if they remember all 3 items, then you can say they're cognitively intact. If they forget all 3 items, you can say they're cognitively impaired or they have significant cognitive impairment. And you only look at the clock and you only score the clock as positive or negative if they can recall 1 or 2 items. Then you use the clock for the score. So very cool, easy to administer, and very valid and surprisingly sensitive and specific. The clock drawing test has also been used as a cognitive screening examination, and there are hundreds of articles on clock drawing. I myself have published probably 6 or 7, maybe even more than that, articles on clock drawing. Really cool test. There are multiple scoring tests, multiple scoring systems for its use. I'm not going to go into any discussion in terms of it. Some people believe, including my mentor, that it is best used as a simple cognitive screening tool. Just look at the clock, say, is it normal, is it abnormal? And if it's abnormal, they say, well, there's something you need to do more. You need to do more testing. So it's a global cognitive screening test. Other people have said, oh no, you can break down individual elements. You can look at the spacing. You can look at the numbers. You can look at the setting of the hands for executive function. And actually those studies have not proven to be very supportive of it as an individual cognitive function kind of test. I'll show you a really cool clock. This was one of my patients. I hand them, I pre-draw the circle, I hand them the paper, say, I want you to draw a clock. And before I could say anything else, they wrote clock, right? They wrote clock. Before I could say anything else, I said, hold on. Use the circle, put in all the numbers, and then set the hands at 10 minutes past 11. So they put in the numbers really well, and then hand at 10 minutes after. Okay? So this person had frontotemporal dementia. Very mild at the time, but he had already significant cognitive impairment. He was disinhibited. That's why he wrote clock immediately, and he had evidence of concrete thinking. So pretty cool. So these are the ones, the tests that I were talking about. You can see how some of them are ultra short, like the clock drawing and mini-cog. Some of them take a little bit more time, like the MoCA or the mini mental state examination. And very good. All of them have reasonably good sensitivities and specificities. Probably good enough to be good screening exams, all of them. Okay, what are the benefits of cognitive screening? So first would be early diagnosis. If you can identify mild cognitive impairment and early dementia before there's significant functional loss, you can intervene, and that will allow for timely intervention care and planning. It helps with correct diagnosis, for example, in Miriam's case. Prevents misdiagnosis, avoids prolonged inappropriate pharmacotherapy and delays in terms of accessing other services. It's good for care planning. It enables advanced care planning. So you can get your legal documents. If you see that this person has mild cognitive impairment, you make sure that they already have a power of attorney. And again, I ask you all as clinicians to not wait till the patient requires a apotropos, but to make sure people get their powers of attorneys done as early as possible. To get a will while it is still valid, and other types of financial planning. Family and caregiver support allows for education, family education, getting community services. It helps in terms of treatment, allowing access to disease-modifying and symptomatic therapies. Now here, this is a big question when it comes to dementias, and particularly Alzheimer's disease. There are now disease-modifying treatments available, like lecanemab, that is available here in Israel. It's very questionable about how valuable these treatments are, and certainly questions about their cost effectiveness. So I mention that because it's important, and things may change. Hopefully things will change in the next 5 or 10 years. The symptomatic treatments are available as well. They are modestly effective, and they carry a significant side effect burden. But again, there are things that can be offered to the family, and particularly if you're a researcher like me in terms of Alzheimer's disease, clinical trials, offering a patient to go into clinical trial is really important. Safety assessment infirms fitness to drive assessment. So, Miriam got lost once, and maybe it's time to think about her not driving anymore. Establishing safety for medication, looking at the falls risks, and home safety. A baseline for monitoring, that goes without saying. And then in terms of system efficiency, as a health system, we need to prepare and plan for an increasingly elderly patient population. And with elderly patient populations comes more cognitive impairment and more functional impairment. And so our health system needs to be prepared for that. What about the risks and potential harms of screening? Obviously, labeling and stigma is a big problem. A screen-positive result can cause social stigma, loss of identity, withdrawal from activities, including work. And I have had patients with very mild cognitive impairment who have said, I'm stopping to work, probably before they should have or could have. But that often can be a problem. And self-fulfilling decline, if you believe in that kind of thing. There's psychological distress that can be associated with this. Now, I'm going to show you an interesting study in a moment that looks at that issue. Screening may provoke anxiety, depression, existential distress in some patients, and particularly those that obviously screen positive. There are false positives to screening. That's important to remember. Many tools are imperfect. They do not have perfect specificity. Delirium can impair cognition. Depression can impair cognition, anxiety, sleep deprivation, pain, so on and so forth. So you really need to be clear that it is a first step in terms of the diagnostic process, and it is not the diagnosis in and of itself. There are also false negatives. And again, I have seen many patients over the course of my career who were university professors and presidents and CEOs of large corporations who had obviously very, very high premorbid IQs. You know, you can have a premorbid IQ of 150 and go down to, you can lose 20 points and go down to 130 and still score perfectly on the mini mental state examination. So you have to be careful of ceiling effects, and you have to be careful of floor effects as well. There's the issue of equity and bias. Many tools were normed on English-speaking, educated Western populations, so you need to take that into consideration. And again, that's why a tool like the RUDAS might be very useful in a country like Israel. There's the consequences of diagnosis. The diagnosis may trigger driving restrictions, insurance implications, employment impacts, or unwanted institutional care. There are limited treatments at the moment. As I mentioned, our disease-modifying therapies and our symptomatic therapies are quite limited at the moment, although they can be offered, and it's my belief that they should be used. And then finally, there's the issue of clinical resource use. If you screen every screen-positive patient, and then you do a full assessment battery, including a CT, an MRI, lumbar puncture, an EEG, multiple laboratory tests, you're obviously going to cost the system a lot of money, and a lot of that will be unnecessary. So there are the consequences of cognitive screening. Okay, so let's take a quick look at the clinical practice guidelines, and we're going to look at both asymptomatic screening and case finding. But first, think about the principles, particularly if you're going to screen an asymptomatic patient population. You want to make sure that you're screening for an important health problem. There should be an accepted treatment for patients with that problem. The facilities for diagnosis and treatment should be available, obviously. There should be a recognizable latent or early symptomatic stage that you can pick up by screening early. There should be a suitable test or examination, like the ones that we've already talked about. The test should be acceptable to the population. The natural history of the illness should be understood. There should be an agreed-on policy for whom to treat as patients. The cost of finding a case, including diagnosis, should be economically balanced with respect to what's available for healthcare spending in your population. And finally, screening should be a continuing process and not just a one-shot assessment. Okay, so that's the principles. So the granddaddy of all screening recommendations is the United States Preventative Services Task Force, which last looked at cognitive screening in 2020. These provide recommendations for all areas of screening in medicine, meant specifically for primary care clinics. And what they said is that the current evidence is insufficient to assess the balance and benefits of harms of screening for cognitive impairment in older adults in primary care. This applies to asymptomatic adults aged 65 or older. So if you're coming in and you're 7 years of age, as a healthy periodic health exam, your 1 year exam, to have your blood pressure checked and your blood checked, if there is no evidence that you have cognitive impairment based on your history, the recommendation is not to screen cognitively. Okay? It's not necessary. And the rationale is that there's an evidence gap. There were no trials that demonstrated that screening and subsequent treatment of screen-detected cognitive impairment in primary care patients actually improve patient-centered outcomes. The screening tools they thought were okay, The harms of screening, they said there wasn't a huge amount of evidence that said that there were harms of screening. However, the I grade, or the insufficient evidence grade, again, applies to asymptomatic population screening and not to clinical case finding, which they would agree with. So this is really cool because the same year that they came out in 2020, they actually published a study that looked at this issue. This was the risks and benefits of screening in dementia and primary care, the Indiana University Cognitive Health Outcomes Investigation of comparative effectiveness of dementia screening. And it was an RCT of 4,000 primary care patients in rural Indiana. They were randomized to either asymptomatic cognitive screening or control, okay? Patients were screened using the memory impairment screen or the mini-cog and referred for a voluntary follow-up diagnostic assessment if they screened positive on either or both screening tests. The mean age of the patient population they looked at was 74 years. 66% of the population were female, and 2,300 or 67% were white. And these were the results. At 12 months, there was absolutely no difference in health-related quality of life, whether the patient was screened or whether they were not screened. There were no differences in healthcare utilization, advanced care planning, and dementia recognition by physicians, whether you were screened or whether you're not screened. And in terms of harm, at 1 month, there were no differences in mean depressive or anxiety symptoms. So even if you screened positive, it obviously didn't seem to affect your anxiety or your depression level. So very interesting. There are lots of weaknesses with this study, and that's probably why it ended up in JAGS as opposed to Science or the New England Journal of Medicine. But an interesting study that really says, maybe asymptomatic screening is not the best possible solution. Now, what about international clinical practice guidelines? So the USA Alzheimer's Association strongly supports cognitive screening. And it even says asymptomatic screening, that it should be part of the Medicare annual wellness visit. So they recommend asymptomatic cognitive screening. But again, they're the Alzheimer's Association, so you can understand the rationale for that kind of a thing. The Canadian Consensus Conference on the Diagnosis and Treatment of Dementia, which I participated in, recommended that screening it's conditional. They recommended screening in terms of a case finding as opposed to asymptomatic screening. The Alzheimer's Disease International also advocated for early diagnosis and recommended cognitive assessment should be integrated into primary care. And the Royal Australian New Zealand College of Psychiatrists also recommended cognitive screening be part of routine psychiatric assessment in older adults. No, so not primary care. So just to sort of summarize that, balancing the benefits and risk, screening is favored when there is a symptomatic patient with functional change, where there are multiple risk factors, for example, old, in other words, people over the age of 75, family history, patients with cerebrovascular risk factors and cerebrovascular disease, clinical suspicion from collateral history, apparent treatment resistance in late life depression, as in Miriam's case, perioperative or high-risk medical settings to check, to screen because they're at high risk for delirium, patient or family concerns about memory, driving fitness or capacity assessment. So these would all favor screening. What you might avoid screening when the patient is when there's an asymptomatic population and you're talking about wide-scale screening without stratification of risk. Patient is acutely unwell, it's probably not worth it unless you're checking for delirium. Screening without follow-up plan or support pathway where the tool is not validated for a patient's education level, language, or culture. Where the patient has clearly indicated they do not wish to know, and punitive consequences with no clinical benefit, like losing driving restrictions, losing driving privileges, or in this country, losing the privilege to carry a gun, and setting lacks capacity to act on results. So in other words, the bottom line is case finding in symptomatic patients is supported by evidence and guidelines. Population-wide opportunistic screening in asymptomatic elders remains controversial. And I would say the evidence currently favors not screening. This is just a way to apply the clinical guidelines. Again, I'm not going to go through this in any detail, and I want to finish up very briefly, just to go back to the case. So what were the implications of my change of diagnosis for Miriam? So the diagnosis was obviously a shock to her and her family, and her family actually needed a fair amount of convincing to agree to the new diagnosis. But I completely stopped her antidepressants. They have a very limited role for the treatment of depression, including major depressive episode in patients with an underlying dementia. And non-pharmacological interventions were introduced. Probably the most important for Miriam was we got a mitapelet for her during the day that would take her to the Beit Knesset, that would take her to the Moadon, that would get her involved back in gardening again, and that really helped her mood significantly. There was the consideration of specific treatments for her dementia, so that I offered the family and her the choice of whether starting on a cholinesterase inhibitor would be worthwhile, dementia care planning, including the use of home supports, and the family was referred to the Amutat Amda. So, final word, cognitive screening of asymptomatic patients is not the same as case finding. Multiple validated tools exist, including things like the mini-mental state, the MoCA, the RUDAS, the mini-cog, and clock drawing. Tool selection must account for culture, language, education, and setting. Benefits can include early diagnosis, correct diagnosis, care planning, safety assessment, and appropriate treatment. Harms might include labeling false positives, psychological distress, system inequities. These must be weighed carefully in population screening. The US Preventative Task Force, again, said there's insufficient evidence to screen for asymptomatic patient populations, but this does not apply to case finding. And all major dementia organizations support case finding in symptomatic older adults, but some of them even include the recommendation to screen asymptomatic adults as well.